Hi, my name is Brian Wormers. I'm one of the nursing faculty, and today I want to talk to you in regarding Sims for pediatrics and your roles as theater students and what you will be doing, what the nursing students will be doing, and just a little bit of what to expect as before you practice. So we've got 4 different simulations. We will start with asthma, and then we move on to like a dehydration from diarrhea, and then we're going to move on to non-accidental trauma, and then we'll kind of do the RSV. Honestly, the first and the last one tend to be a little bit easier, just because trying to ease them into sim and ease them out of sim. The middle 2 are a little bit harder. When we work, so that's kind of the morning setup. In the afternoon, we'll often revert back, and so we will often do a flipped situation. So we'll start with the RSV and then go into the NAT and then the diarrhea and dehydration and then go back to asthma. It's just easier for setting up mannequins and doing that kind of stuff. So I've sent you out the different scenarios and what you can see. This is what the students will get, so they know that they're going to work with somebody. So on this one, they're seeing that, Susan Falls is a 15-year-old female. She's in with asthma exacerbation. She went through the emergency department with an increased work of breathing. And so she's had multiple times the ER, so this is her 3rd visit now. And she's probably wasn't expecting it, but now she's getting transferred to the general pediatric floor for further treatment and evaluation. So mom wasn't expecting this, so mom went home to go grab some equipment and some clothes and some different stuff like that. And so now this patient is here by herself and probably not happy and is having difficulty in breathing. For the sim, you will play the role of the patient. And so, like I said, this is usually a 15-year-old female with asthma. So orders for this, the nursing students can give albuterol every 4 hours, but she just had it about 2 hours ago. And so what they need to do is do a good head-to-toe assessment on this patient, then call the provider, and the provider will tell them to switch from every 4 hours to every 1 hour. They can give this med, and then life is good. So for this aspect of it, this is kind of our flow sheet for what happens. We start here with our initial vital signs. This is what we'll have on the monitors within the room, and this will all be controlled. No, if you're playing the role of the patient, no, I don't expect you to try and manipulate your heart rate to be this or manipulate your blood pressure to be this. But these should be close enough. So what we want to see is that they put oxygen on you. The oxygen is just nasal cannula. It should be a clean thing that hasn't been on anybody else. They'll hook it up to the wall-mounted thing. It's all clean and sterile. So let them do that, and that should be all right, whether that's mask or nasal cannula. All that equipment should be clean, and it's not a big deal. It shouldn't hurt you at all. They should do an assessment, how are you talking? So with asthma, what I'm expecting to see is that you're going to be only using a few words before you have to try and catch your breath. And so you're not speaking in full sentences. And with asthma, you have a hard time getting rid of your air. And so you can get the air in, but you have a prolonged expiratory phase, is what they call it. And so with this, whoever gets to play this character is going to be a little anxious, a little nervous, because that's normal if you can't breathe. And you're just going to be a little short of breath, broken speech. You're a little nervous because your mom ran home, and although you're a big, teenage girl that's fairly independent, you still miss your mom sometimes and the comfort that can bring. So she might be a little whiny, she might be a little needy, and that's completely fine. That's part of the role. The other fun thing that we like to do with this one is hit on somebody. So I know that that's a weird thing, and you never thought you'd probably have to do this. But within the simulation, or within the hospital setting, it is unfortunately all too common that your patients will hit on you. So you can hit on somebody, and this can be a boy, this can be a girl, this can be, whatever, whoever. But the situation is so that people learn how to think about this and how am I going to deal with this. a 15-year-old hitting on you is kind of cute and it's not a big deal, but they're going to have to deal with creepy old men, creepy old ladies, and what are they going to say in these situations? So like I said, your role, you're short of breath, you're a little anxious, you're a little scared, you're having, a decrease or an increased work of breathing. Mom's not there. And so you can kind of make up whatever your story is. Like, was there any triggers? Do you have an allergy to, any of the seasonal stuff, the pollen, the trees, any of that kind of stuff? Is it stress from school? Is it hormonal? Is it, whatever you say, honestly, can be a trigger for asthma and cause an asthma exacerbation. So you're here, you're not really well cared for because you've been seen numerous times this year. And that's kind of where we're at. And so, like I said, what I want them to do with this one is, apply oxygen, call the doctor, and then they'll give you albuterol. The albuterol is really just saline. It's going to look like a mist, but all it is just like a cool mist, and it won't hurt anything. There's no meds. You're not going to get a real albuterol treatment, and the albuterol mist won't hurt anything. They might not know how to set up the albuterol treatment, and that's part of this one. The other thing is if you want, we will have a puffer sitting out, and you can try and talk them into letting you do the puffer instead of the neb treatment. And so the neb is, it's a bigger, clunkier device that they got to put liquid into, and then hook it up to oxygen or hook it up to air, and then it kind of blows kind of a mist at you. I think most people have seen little puffers. You can try and get them talked into doing that instead, and we'll see if they do that. There will not be any med in that puffer, and I'll wipe it off and stuff like that if you want to use that with a spacer. But that's kind of that one. We'll talk about it afterwards. I really like it if you can do the debriefing. I'll try to be cognizant of your time, and I'll include you first because I like to ask you, how did you feel? Did the nurses comfort you? Did you feel like they were taking care of you? Did you feel like they were professional? Did you feel like they knew what they were doing? Did they respect you? What did they say that you liked? What did they say that you didn't like? And then they can I'll have them give you feedback on your performance of, was this believable? Was this something that added to the simulation, which it always does. It's always amazing. Keys for you is really try to sell it. Don't go into it playing around or joking or something like that. It's so much more fun if you're all in. If they start laughing and giggling because they're uncomfortable, call them out on it. Why are you laughing? This is something serious to me. And you'll snap them back into that situation, and it really helps them learn and grow and develop as nurses. So that's kind of the asthma situation. If you have questions, let me know. Also, with these situations, if I get your cell phone numbers, we can text back and forth, and we can do those kind of things as well. And if you have any questions during the sim, we can text because having a 15-year-old text is not unheard of. And we'll go like that, and we can do that for all the other characters too. So if you get your cell phone, I can give out my cell phone number, and you are free to text me with any questions that you have during the sim. Moving on to the next sim, what we'll often do is this diarrhea. So Cooper the Pooper. So I do like to name play a little bit. So the first one is Susan Falls, so Sioux Falls. Cooper Catamount. Cooper is the name of our mascot here. Catamount's another name for a cougar. But he's a 2-year-old male in with dehydration and diarrhea. Caregivers on this one are interesting. You can either do one caregiver or two caregivers. But you're the parents, and you are going to be those parents, so to speak. This little kiddo is dehydrated, but parents don't want to do an IV. Been crabby all night, not feeling good, and so that's kind of the basic story. But what the caregiver doesn't realize is this little kid is so dehydrated, he's starting to get obtunded and not. It's beyond just being sick. He's starting to not respond and not react appropriately. So what I want you to do as caregivers of is, of course, first and foremost, I want you to kind of stop them and say, he's sleeping. Can you come back another time? Can you do these kind of things? Eventually, you have to yield and you have to let them do their assessment. Otherwise, this goes nowhere in sim. But eventually, they should talk you into, yeah, we need to do vitals. We need to do an assessment. We need to do these kind of things. And finally agree, but just be like, just try not to wake him. So as they're going through with this, hopefully they realize that this little kiddo is not acting quite right. It's a little sleepy. You're going to see vital signs changes of dehydration, which include increased heart rate, decreased blood pressure. And like I said, he's overly sleepy, which isn't right for a 2-year-old. He will have a loaded diaper on him. It might smell. That's normal. It's going to be full. And that's part of having them deal with this. If they're good, they're going to wear isolation gear, so they might wear gowns and gloves for this. Most do not. I will let you in on a secret. Within that diaper, we put some glow gel, and what that does is it will shine when we shine a black light. And so we do it to try and do isolation and talking about maintaining, not spreading bacteria and that kind of stuff. But what we'll commonly see is that they spread the bacteria from the diaper that's kind of leaking out and stuff like that to the handrails and their pens and their phones and their scrubs, and maybe even their stethoscopes. So realize that's part of the big nasty wet stool too. Hopefully they realize that this kid needs an IV. They call the provider based on the vital signs. Like I said, the kid's not going to be rousing at all. For you as a caregiver, you're going to maybe see if you can get them to let you feed the baby with a water bottle. It's a real bottle, but please don't fill it up with anything because we don't want to short out the mannequins. But see if you can, can we just try some oral fluids? Can we do these kind of things? If they agree, so that is kind of a trick. If they agree to this, then the baby's going to start coughing and sputtering and aspirate on the stuff. But I want you to see if you can let him, if they'll let you feed this baby that's, too sleepy. Hopefully they will stop you at that point in time and you won't be able to feed anymore, and they should give you rationale and reason for that. After they call the doctor and they get the order for the IV and the IV fluids and stuff like that, they get put in a double bind because the doctor will say one thing and you're going to be like, no, I don't want an IV. Once again, you have to yield eventually after they give you what you feel is a good enough excuse, a good enough reason. So then they will do the IV. They get to do it on this little mannequin and put the needle in. When that happens, we will tell them that their IV attempt had failed. At that point in time, you can go ballistic on them. And don't you know what you're doing? Even before the IV, you can be like, so you've done this before, right? You're an expert with this. Lead with that kind of stuff because it really sets them up for what happens if they fail. And whoever does the first one, it will fail. It's nothing that they did wrong. It's nothing that their technique or anything like that. It's just the simulation of it. But when that first one does fail, you can go ballistic and say, I thought you knew what you're doing. You said you were an expert. You said you had this. And now you just poked my baby when I didn't want you to do it. They're going to have to come back and say, we need to try again. You let them, but you can give them a hard time about it. But once again, you have to let them try. Once they get that second, whoever does the second IV, they'll get it, and that will be the end of simulation right then and there. And so then we'll talk about some different things, and that will be the end of this one. So this one's really kind of a fun one because you get to harass the nursing students. But like I said, just really get into it, be serious about it. If you start laughing and giggling and stuff like that, it does kind of wreck the fidelity of sim. And then we'll debrief about it. And once again, we'll talk about, how were they comforting, how they make you feel, all those kind of things afterwards. The next simulation is a little bit tougher. This one is talking about non-accidental trauma. And so commonly referred to as like shaken baby syndrome. We don't like that term, and we'll go through that with the nursing students about that. But this little kiddo is university, so play on words again. but he is just a 4-month-old male, so just a little baby. He's got a history of being in the NICU. He's got a history of feeding difficulty, so he'll actually, through his stomach, he'll have a little tube that you can put food in because he's having feeding difficulties. He also has reflux, which some of you might know that term, but basically he's taking some of his stomach contents and it goes up his feeding tube, and sometimes even high enough that's going into his airway. But it burns and it stings, and these little kids can be very crabby because of it. So with that, he's also got a Nissen. A Nissen is a surgical procedure in which they take part of the stomach and wrap it up to try and stop the reflux from happening. I don't expect you to be aware of what all that stuff is, but just that he's got this. So that's the back history on Uni. He is just a littler guy, but what's going on is that you will bring him in with seizures. What really happened is that you or somebody abused this child. And on this little child, we're going to fake some bruises on the front of his chest, just 2, that would be actually thumbprints, and then a total of 8 little bruises, which would be the fingerprints. So somebody grabbed this child and shook him and caused trauma and gave him a head bleed. Within that, what the nurses will see will be like a bulging fontanelle. The pupils will be a little different. This kid's going to have start seizing. The seizures on this mannequin is just kind of a light flapping of the arms. Your story can change a little bit, which is good. We're talking about this kind of situation. If there is a guy that can play this role, I would like that because of statistics, and we can cover that later, but it's usually a non-biological male caregiver. And as a guy, that kills me a little bit, but that's the stats. So non-biological caregiver is also a big factor for whoever plays this role. If it's a guy or a girl or whoever, I want you not to be the mom and not to be the dad. You are going to be mom's boyfriend or mom's girlfriend, and you are not related to this kid. Don't overtly tell them that. If they ask, by all means, you tell them. However, if they don't know and they're giving you, they can break HIPAA and privacy acts and stuff like that. So it is kind of setting them up a little bit. So that's really what's going on with this one. You are kind of anxious in your role. You kind of want to know when to leave. Like, when's the doctor going to get here? When can we go? Is he going to be all right? You're a little distanced. You might be on your phone. You might be texting. You're not really right at that bedside and being an attentive parent. When they ask what happened, a good story, you can make this your own, but the child was laying on the couch and then rolled off onto the floor, which does have carpet if they asked, and afterwards he started having these weird tremors. And so you watched it for a little bit and then they went away. But all these different details. Be very specific about this. Like, I don't know, the color of the couch and the floor and how this all happened and all these different details about the situation. But then kind of change up your story a little bit and say, oh, but I was in the other room. I was making breakfast, or I was making lunch, or doing these things. So all the details about what happened to this child, but yet you try and distance yourself and say, oh, but I was in the other room when this happened, or the dog knocked him off the couch, or the dog knocked him out of his high chair, or some kind of story like that. If you have some discrepancies within your story, or if your story changes a little bit, that makes it kind of interesting with this too. But we're going to kind of take the role that you abused this child, you brought him in, but you are trying to get out of there. If they talk about the mom or the other people involved, say, yeah, I'm texting her, I'm keeping her updated and stuff like that. In reality, you are not, but we can say that. We will give you a package of fake cigarettes if they start asking really tough questions and you're making you uncomfortable. By all means, you can take a smoke break. You can come back and chat with us for a little bit until things calm down a little bit, and then you can go back out there. Of course, you are not going to threaten the nurses. You are not going to threaten or hurt the baby while you're in there. That's not this role. But if you can, try not to have them lift up the baby's shirt or look at the skin. Just say he's cold and let's just try and keep him covered. If you go too far with that one, then of course that gets really suspicious, and then the nurses want to look. But if we cannot do that and try and keep him, just I think he's cold. Can we put a blanket on him and try and divert him from that? Trying to think of what else to tell you on this little kid. Like I said, you don't have a story that he fell out of the high chair, or the dog knocked him over, or he was on the couch, or something like that. But you were at a different spot. Your stories can change just a little bit. Make it subtle. And I think that's kind of the role. Like I said, this is kind of a fun one. They kind of beat themselves up on this one because it's like, once you start seeing all the pieces of the puzzle put together, it makes sense. But until you have all the different pieces, it doesn't always click in their minds. So just be aware that they can be hard on themselves. In the past, when we've done this, sometimes the nurses have even gotten very angry at this person, which previous theater students have just absolutely loved, that they really got a strong emotion out of this. And it's just a commendable thing for how well you are doing in your role. They won't hurt you, I promise. But they might get frustrated with you or nervous about you, or if they think that you're the one that hurt the kid, their expression might change, and you might see them act in a different fashion. They're not going to take a swing at you. They're not going to do anything to hurt you. If that happens, by all means, we're stopping sim and we're taking a break. And kudos for you for eliciting that strong of emotion, but it hasn't ever come to that, and I won't let it get to that. So with this kid will start seizing. The nurse will have to call the doctor, give him a report on that one. They'll have to give him medicine called Ativan. They can do that, every 3 minutes, up to 2 doses. Of course, this child is going to continue to seize, and so the Ativan isn't going to work. They're going to have to call the doctor back and switch meds and have to do other things like this. After they get the report of, the new med and the CT and labs, we'll probably end it there. So that's kind of how far this one will go. But once again, afterwards we'll do a little debriefing, and you can say what was comforting, what was not, what was good, what the nurses do right, and they can give you some feedback on your role too. So final one on this one is going to be RSV. So RSV is an upper respiratory thing. Think of it like an influenza, but this is going to happen on a 4-month-old child. So for this one, I'm going to give them an oral report. So I'm just going to tell them the report. They don't get the sheet, and that makes them a little nervous, just because it's something different. But she's a 4-year-old female, is brought to the emergency department. She's having some difficulty in breathing, difficulty in feeding, which is very common for these kids that get RSV. Immunizations are up to date, no known allergies, and generally has been doing well at home. She does have a history of being a little bit small. She was born at 34 weeks, and so she was slightly premature. She spent 5 days in the NICU. And needed some oxygen shortly after birth, but since that time and since being discharged home, has been fine. No meds, no oxygen, and no difficulties. Mom, family will bottle feed her some Similac formula every 4 ounces every 4 hours. Had a wet diaper in the emergency department, but the caregiver will say that she's not eating enough, drinking enough, and all those are down. These are vital signs, so relatively normal, a little high on the temperature, a little high on her heart rate, but for an infant it's not bad. Downstairs in the emergency department, she was positive for RSV, so that's what she's coming in with, but no other labs are pending, no other labs are drawn. I'll give her the orders, so the nursing staff should keep SATs greater than 92%, do IV fluids, place an IV. I'll tell them that we didn't do it because, they're the experts up there, and so we left that for them to do, which they're always excited about, sarcastically, he says. But along with that, they can give some Tylenol for pain or fever. And just overall, nice kid, nice family. And for your role, you get to be a family with this one, and overall, you are nice. You are going to be a little stressed, though. And what's going to make this one stressful is this little baby will cry and make noises, and the monitor is going to go off, and you're going to hear lots of like beeping and alarms. And so all the stress of all these different stimuli going on is part of the simulation. Is how are they going to deal with a family member that's probably anxious because their kid is crying and the alarms are sounding. What does that mean? And this one's flashing, and they should be able to explain to you what the different things on the monitor are and what they're doing about that to improve it. In reality, this is one of the simpler sims. Basically, what I want them to do is, suck out the nose of this little kid who's going to have lots of secretions, and you will see that we're going to manufacture some of that stuff. They need to suck out the nose, wipe off the boogers, and then just put on some oxygen. And that's really what I want to see them do. But they're trying to do an assessment. They're trying to deal with the monitors. You can ask them questions. And just be a little anxious and a little nervous, and they should, hopefully they'll calm you down, and they'll take control of the situation. If they start ramping up and elevating and getting more nervous, then you can ramp up and elevate and get more nervous. You can kind of match that energy in the room. So if they're starting to freak out, then you start freaking out, because that's usually what happens, is that the family will meet that nurse where they're at. And so sometimes the family will be a little excited and doing those kind of things. And you're concerned when you first start off, and you don't like all the beeping and stuff like that. But by all means, you can elevate if you're starting to pick up on the nurses is acting like that too. So, yeah, but that's kind of this little kiddo. Like I said, baby will be crying. The monitors are going to be going on. There's snot, fake snot. And that's kind of what this one is. And your role is just a concerned caregiver. Ask them questions. What is this? Why are you doing this? What is RSV? What does that mean? How long are we going to be here? Just normal things. Once they suck out the nose, once they put on some oxygen, the baby's going to actually start being cooing and laughing, and will be doing better with that. So you'll get to experience that too, and then that kind of changes that whole room environment, and it's kind of a nice way to end that sim. Questions that I've had previously through like working with theater students is you probably can't ever go over the top, and I know working with previous students are like, well, what about this, or what about this? And I'm like, I have seen so much from patients smuggling marijuana in a Playboy into a patient's room, to grandma drinking beer at the bedside, to a mom bringing two guys home or not home, but into the patient's room and had a menage a trois. So we will see very, very interesting things, and you could take this in very, interesting ways, and I can let you run with it. Don't go so over the top it's not believable, but that being said, the stuff that I've seen in my life, some of the stuff you see is maybe not believable. So come up with your stories, make it your own. You can have whatever names you want for your patients. I don't have any names listed on here except for the patient names, and that's because we need to have ID bands on. So whoever does the asthma one, that name is kind of stuck because we need the ID bands, and all these report sheets and stuff like that are assigned for them. But I hope that this kind of clears up some of the expectations, what you get to do. It is a lot of fun. It's kind of the ultimate theater in the round in which you get to interact with your audience. And that being said, it'll be fun. It always is. But just try to make it as realistic as possible for this. If you have questions, feel free to email me, call me. I'm happy to help. Lindy, I'm sure, would be happy to help as well. And she's going to give you a tour of the sim lab and orient you to kind of the flow of this. But yeah, so that's kind of the rundown. So any questions, feel free to contact me. And I can't wait to have you in the sim lab. It's going to be so much fun.